Hello to everybody. Philipp Mathmann, my assistant doctor and nearly complete phoniatrician and pediatric audiologist and opera singer. We feel very honored to host this webinar and to celebrate the World Hearing Day with you. This is a special World Hearing Day because today the World Report on Hearing has been launched. I had the privilege to be as a member of the German Society of Audiology, also part of the authors team and reviewer team and advisor team, and we worked hard for more than 2 years on this World Report on Hearing. And it is really not my merit, but I can say this is a very exciting report. It is 272 pages long. It's a book, so to say, and it's absolutely worth to be read and known by all of us, by the people from our profession, because it is a wonderful summary of what is known about hearing and hearing loss prevention, causes, treatment, and the meaning for the society. All the new literature on evidence about nearly each statement in this review has been gathered together and reviewed strictly. And what is also very exciting is that the World Report on Hearing, which should improve the fight against hearing loss and related disability, contains a new classification of hearing loss, which will for sure change the prevalence data we have worldwide on hearing loss and change the whole picture of hearing loss, of its assessment, of its treatment. What we try today is to show a part of this report. So it's a little bit boring for you. You can intervene and can discuss points with Philipp and me. We record this lecture, so to say, so we have a lot of text from this report. Let me start very generally. The sense of hearing is a key aspect of functioning at all stages of life. Its loss, unless appropriately addressed, impacts a society as a whole. We always have to keep this in mind. Hearing, you know, is the sense with which we perceive the sounds around us through hearing. We engage with our environment, communicate with others, express our thoughts, and gain education. Globally, you will hear this number repeatedly today. More than 1.5 billion people experience some decline in their hearing capacity during their life course, of whom at least 430 million will require care or already require care. Loss of hearing can have far-reaching consequences. Many causes, much more than we thought so far, of hearing loss can be prevented. For example, more than 1 billion young people put themselves at risk of permanent hearing loss by listening to music at loud intensity over longer periods of time. Clearly preventable. The past few decades have seen game-changing advantages in technology, diagnostics, treatment, telemedicine, with respect to treatment of hearing loss. Ear diseases and hearing loss can nowadays be identified at any age and in any setting. We have solutions, medical and surgical management, hearing aids, cochlea and other hearing implants, rehabilitative therapy, sign language captioning, where people with ear diseases or hearing loss can have access to education and communication, and thereby have the opportunity to fulfill their whole human potential. Most people, 80% of people with hearing loss, live in low-income settings. So what the WHO expects also by distribution of this report is that the governments do more to integrate ear and hearing care in their programs. The WHO provides evidence and tools for them to do this. And if you look to the website of the WHO, the nice brochures on situation analysis tools, manuals on establishing an ear and hearing care system in a country, it's very helpful. The public health must take into account the ongoing demographic changes. A rise of more than 1.5-fold in hearing loss is anticipated in the coming decades. That what is a lot. So the goals of this report is to make ear and hearing care a global public health priority through presenting its relevance across life course. This is the feature of this report. It goes along the trajectories of a life and addresses hearing loss that way. And to define a public health approach for addressing this form of care from the prenatal stage to adulthood into older ages. And most countries do not have this public health approach. So the objectives of the report are establishing hearing loss across the life course as a public health priority among policymakers, to draw attention to the existing solutions to prevent and rehabilitate hearing loss, as well as the challenges in their delivery and getting access for everybody to hearing, better hearing if necessary, documenting scientific evidence and country experiences, making recommendations and setting targets that stimulate country-level action for improved access to ear and hearing care. Through the integration of the hearing package of interventions, Philipp will talk about it, as part of a universal health coverage. The next steps which are necessary are to promote the implementation of recommendations by WHO member states. If you remember, we had a resolution on the prevention of deafness and hearing loss in 1995, where the WHO already urged its member states to establish such programs and screening programs, healthcare programs. However, in 2013, it has been evaluated, what the outcome has been evaluated, and there were only 32 states which had implemented such programs, and there was a dearth of data, of evidence-based big data, and this is the necessity for the next decades. Okay, exerting from the fact that each individual has a unique hearing trajectory that is shaped by diverse influences experienced throughout the life course. This trajectory, it's my difficulty to speak out this word, trajectory determines a person's hearing capacity at any point during the life. And there are causative and protective factors which influence the hearing capacity of a person. Although factors influencing hearing capacity can be encountered at different periods of a person's life, some factors are more likely to be experienced, or individuals may be more susceptible to their effects at specific points in life. For example, in the newborn period or before, there are genetic characteristics or biological factors like nutrition of the mother. Later, behavioral factors such as lifestyle choices are added, or environmental factors of noisy environment. The hearing capacity is commonly measured using pure tone audiometry and classified based on the audiometric hearing thresholds, but that's not all, as we all know. The impact of hearing loss on a person is determined largely on whether the hearing loss is addressed by effective clinical or rehabilitative interventions. Often it is not. Unaddressed hearing loss can negatively impact many aspects of life: communication, development of language, speech in children, cognition, employment, mental health. Hearing loss can cause low self-esteem, is often associated with a stigma, and can significantly impact the families and communication partners of those living with the condition. We often forget about this. So hearing is a key component of human intrinsic capacity. It is the sense most relied upon to communicate and engage with others. Any decline in hearing capacity at any point during the life course, if not addressed in a timely manner, can adversely affect day-to-day functioning. So here we have a bunch of causative factors which influence hearing. I will speak about them, and here protective factors which interact with each other. Let's talk about determinants of hearing capacity. Many determining factors, such as genetic, biological, psychological, and environmental, are experienced at different stages of life. Many ear conditions are treatable, and many causes of hearing loss can be avoided by taking preventive actions at a personal level. Both causative and preventive factors interplay to determine the occurrence, nature, severity, and progression of hearing loss. Thus, the hearing capacity of an individual is determined by the baseline hearing capacity at birth, of course, by exposure to or presence of causative factors, genetic, biological, behavioral, or environmental, and protective actions mitigating the risk factors. The individuals are most susceptible to the effects of these factors during critical periods in life, as I mentioned, such as before birth or in the first years of life, a period of physiological development and maturation for the hearing system and critical for language acquisition. The impact of risk factors for hearing loss is also higher in older age groups when neurodegenerative changes set in. So I do not need to explain the ear and hearing mechanisms to you. Let's talk about the report deals with the causative factors for hearing loss. I show only some examples. It's very nicely illustrated with the pictograms. There is something in the chat. Let me check whether it's something I need to know. Okay, no, not for the moment. Okay. So, genetic factors. Interestingly, we have 11 known syndromes. I thought it would be more. such as the Usher syndrome. An important factor is parental consanguinity. As I just have shown in the presentation before, in Pakistan, the prevalence of congenital hearing loss is 15 per 1,000, and this is related to high parental consanguinity. So what is always outlined then is the influence on hearing. For example, over 250 genes are associated with hearing loss, which are commonly hereditary in nature. These include autosomal dominant, autosomal recessive, and X-linked genes. In many communities across the world, consanguinity account for 20 to 50% of all marriages. So syndromic hearing loss is accompanied by additional clinical features in visual, nervous system, endocrine, and other systems. We need to keep this in mind. Genetic factors are responsible for over 50% of hearing loss encountered in neonates and account for nearly 40% of childhood hearing loss. And non-syndromic hearing loss accounts for 35%, syndromic for 15%. So then we have the intrauterine infections. You see them here, toxoplasmosis, rubella, cytomegalovirus as the most important one, but also herpes simplex, HIV, Zika, syphilis, and others. Hypoxia or birth asphyxia, the lack of oxygenation experienced at time of birth, measured or expressed by a low APGAR score, which is addressed in the minutes immediately following the birth. Okay. Hyperbiliorubinemia. I extracted what is meant with hyperbiliorubinemia. It's often not quantified. The risk is greatest in infants with bilirubin levels higher than 20 milligram per deciliter. And it's potentially reversible, but the higher the hyperbilirubinemia in neonates, the less high is the option to go reverse. The low birth weight. So far, it's known that a low birth weight below 1,500 grams is a risk factor, but it may be less nowadays. It has to do with premature birth or also with maternal undernutrition. Other perinatal morbidities and there are, for example, CMV infections in preterms and meningitis, ototoxic medicines, which are used to treat these infections, newborn infections. And it is observed that infants managed in neonatal intensive care units have a significantly higher likelihood of developing hearing loss. And it is a mixture of such infections, preterm birth, low birth weight, hyperbilirubinemia, loud noise in the incubators, genetic influences. These are the factors I mentioned, which are responsible also for hearing capacity. So in childhood and adolescence, otitis media plays a large role, not in Germany any longer. There it's only the non-suppurative otitis media with ear effusion, but worldwide, otitis media makes up a considerable factor for hearing loss. In most cases, mild to moderate conductive hearing loss, but we have also the disruption of the ossicular chain with higher degree hearing loss, the erosion of the ossicles, ruptured eardrum, and also sensory neural hearing loss or severe hearing loss may result from otitis media. And if you go to countries like the Philippines, where I have worked a little bit with colleagues in newborn hearing screening, teachers there are used to that children have permanent ear secretion. It does not hurt. Everybody knows it. Children swim and dive, and everybody is used to chronically discharging ears, which we do not see here any longer so much. So otitis media is the leading cause for healthcare visits and morbidity overall globally, especially in children. An estimated nearly 99 million people or more are affected by hearing loss as consequences of acute or chronic suppurative otitis media. Let's talk about meningitis and other infections. They are common in childhood, such as measles, mumps, and meningitis. Other factors, other infections are caused by Borrelia, Epstein-Barr virus, Haemophilus influenzae, and so on. Meningitis may be responsible for 6% of sensorineural hearing loss in children. Overall, an estimated 14% of those infected with the pathogens may suffer hearing loss, of which 5% can be very profound. Okay, why is smoking an influencing factor to hearing? Due to the antioxidative and vascular effects of cigarette smoke. And there is also a direct ototoxic effect. Most people don't know that. Otosclerosis, of course, an abnormal bone growth inside the ear, which affects the stapes and sometimes also the cochlea, can cause conductive, mixed or sensory neural hearing loss, and can be managed effectively through surgical and non-surgical means. But also chronic diseases, comorbidities such as hypertension, diabetes, central adiposity influence the hearing. And we just run a study on the implementation of universal screening for people with intellectual disability, where we also check for these factors as potentially worsening a hearing loss or causing it. Age-related, in adulthood and older age, age-related sensory neural degeneration plays a major role. The degenerative changes to the structures within the ear associated with aging. They affect the ability of the inner ear and higher centers to process and discriminate acoustic signals, presented as difficulty in hearing some sounds and in discriminating speech. Some degree of hearing loss in 60%, 65% and moderate or higher grade in hearing loss are there in nearly 25% of the group of persons over 60 years of age. The prevalence of hearing loss doubles in studies in the United States during every decade of life from the second to the seventh decade, with the sharpest rises occurring in those aged more than 80 years. I will show you the graphics later. The sudden sensory neural hearing loss is well known to us, but we have other non-modifiable risk factors, such as syndromes which come in later in life. The Usher syndrome, Hunter syndrome, Friedreich's ataxia, gene mutations that commonly manifest later in life. Cerumen impaction. I'm very grateful that the WHO wrote, or the authors wrote, that impacted earwax is not such a problem as many people think. It's a secretion produced by the ceruminous glands, which are physiological glands in the outer ear. It is sticky, waterproof, and protective in nature, with bactericidal and fungicidal properties. Cerumen traps and removes dead skin cells, dust, and other materials from the external ear and belongs into an ear. It's rather rarely that it completely occludes the ear canal and makes small shifts of 5 to 10 decibel in the hearing thresholds can occur by it. Its impaction is often aggravated by the use of cotton-tipped swabs for cleaning the ear canal. But some 10% of children and 5% of adults have impacted cerumen. Over 50% of older adults may be affected as well. Then we have trauma to ear or head, for example, also by surgery, but of course more by polytrauma. Loud noise and loud sounds. We have three kinds: occupational noise, recreational sounds, and environmental noise. They may damage the hair cells and other structures within the cochlea. High frequency range is affected at first, and other noise-induced health problems such as insomnia or cardiovascular illness, for instance, by living in cities, traffic noise has to be taken into consideration. 16%, 7 to 21% across different regions of hearing loss in adults result from such exposure to unsafe level of sounds in recreational settings. Noise in sporting events can reach levels as high as 135 decibel. So we see the famous Vuvuzela. So we have ototoxic medicines. We know more than 600 categories of them. Most commonly used are aminoglycosides and macrolide antibiotics, chinulin, platinum, loop diuretics. They may have cochleotoxic or vestibulotoxic or neurotoxic effects. They are dose dependent and cumulative. We just heard that after giving children cisplatin, they need a follow-up of at least 3 years because of cumulative effects. Their influence may be affected by other factors such as age, gender, genetics, susceptibility, and comorbid conditions. The incidence of 63% with aminoglycosides and 6 to 7% with furosemide is quite high. Cisplatin causes tinnitus and hearing loss in 23 to 50% of adults and up to 60% of children receiving it. 50% of those treated with injectable medication against tuberculosis develop permanent hearing loss. So other factors are work-related ototoxic chemicals like printing, painting, boat building, construction, glue manufacturing, metal products, chemicals, petroleum, leather products, and so on. In Europe, about 11% of workers have reported exposure to solvents and thinners. 14% handle chemical substances. Nutritional deficits. For example, undernutrition with vitamin A, zinc, iron also influence hearing. For example, there was a large cohort study in southern Nepal where early childhood wasting and stunting was consistently associated with a 1.8 to 2.2-fold higher risk of hearing loss in early adulthood. Other viral infections. Did you know that 14 to nearly 50% of HIV patients experience a consequence of the disease or treatment with potentially ototoxic medicines for hearing? Ebola survivors and Lassa fever virus as well. I was involved in the group of Zika virus infections, which also have very often hearing loss. Okay, there are other factors. Here you see the steep slopes which of hearing loss, of prevalence of hearing loss in elderly people, region dependent, starting from age 60, the dark red, up to over 90. And you see how quick it runs. And all people over 90 have moderate or higher grade hearing loss, not all, but more than 50%, nearly 2/3. Okay, let me rush through the factors across lifespan. It's really interesting what all you can do to prevent hearing loss. For example, balanced maternal nutrition during pregnancy. Many females in the world do not have this. Maternal hygiene, we cannot imagine that it is important, so important. However, indeed, frequent hand washing and peeling of fruits and vegetables, it plays a large role in low and middle income countries. Breastfeeding is so important for immunological reasons, but also for protection against otitis media. Did you know that? By sucking movements of the velum and ventilating the ear, and also by the immunological effect. Good ear hygiene means don't put anything in the ear. No cotton buds, clips, toothpicks, sticks, or candles, ear candles. Don't ignore an ear that has any pus or fluid coming out of it. Don't treat any ear conditions with hot or cold oil, herbal or home remedies. Don't swim or wash in dirty waters. And another recommendation of WHO is clear: don't listen to very loud noises or music for a long time. Avoid tobacco. Okay, nutrition I mentioned. For example, balanced nutrition can reduce sensory neural degeneration associated with noise exposure. It's a protecting factor, and aging, and protect against childhood purulent ear infections. For example, not too much sugar, or supplementation with omega-3 fatty acids, vitamin A, C, E, and folic acid, as well as magnesium, zinc, and iodine, has been shown to be beneficial for the auditory system. Of course, general healthy lifestyle play a role. Diet, alcohol intake, smoking, substance abuse, and recreation play a role. Immunization, very important. It protects against many diseases, including rubella, meningitis, mumps, measles, and their associated hearing loss. Okay, there are a lot of recommendations about avoiding loud sounds and loud noise. For example, keeping the volume of personal audio devices below 80 decibel. Staying safe is to listen at a volume below 60% of maximum. Use of noise cancellation earphones or headphones might be important. Check the surrounding noise by smartphone applications. For example, in Hungary, they have mandated that in children events there has to be checks by apps of the sound exposure. Okay, I want to mention very shortly the new classification of hearing loss. Fortunately, it came down. So normal hearing is nowadays, if you take the average of the 4 frequencies, 0.5, 1, 2, and 4 kilohertz, less than 20 decibel, this is for adults, is normal hearing. Mild hearing loss nowadays starts at 20 to less than 35 decibel. So far, it was 30 decibel, or 20 for children, 25 decibel. Why did it decrease? Because formerly WHO focused on hearing loss that can be measured also in middle income and low income countries. But nowadays they say no, according to the ICF model, hearing loss is what you experience as hearing loss and what restricts your participation, activity, and self-esteem, independency. And this starts at these levels. Moderate to hearing loss, 35 to 50 decibel, 50 to 65, moderate to severe hearing loss, and so on. And also, unilateral hearing loss belongs to this classification now. It is less than 20 dB in the better hearing ear and 35 dB or greater in the worse hearing ear. Here I want to show you that the vast majority of hearing loss is a mild hearing loss. 1.16 billion of the 1.5 billion people who experience hearing loss. Okay, but you see together about 1%, nearly 1% severe, profound, or complete hearing loss. And here again, age-related hearing loss, and here you have the steep slope starting at ages of 60 up to 95. 58% of moderate or higher grade hearing loss is experienced by adults above the age of 60 years. Here we have the distribution of hearing loss, and the maximum share is in the Western Pacific region, and Southeast Asia has also high prevalences. Northern America, maybe because people get older, it's not completely clear. But nearly 80% of people with hearing loss live in low income and middle income countries. One last part about the economic impact. In 2019, the global number of years lived with disability were attributable to hearing loss. It was 43.5 million years lived with disability. This number has increased since 1990 by 73%, probably due to aging of the population. Age-related hearing loss was the third largest source of global years lived with disability in 2019 and the leading source for adults older than 70 years of age. 65% of disability caused by hearing loss is attributed to moderate or higher grades of hearing loss. Okay, but the hearing loss, which is felt by people depends on whether it is addressed with effective clinical or rehabilitative interventions, and by the extent to which the environment is responsive to the needs of people with hearing loss. This is also an important factor. The impact can also be influenced by other coexisting functional limitations, such as vision impairment, autism, or developmental disabilities. Dual sensory sensory loss, as deafblindness, affects as many as 0.2 to 2% of the global population at all ages. Did you know that? It's a high number. Okay, the impact on an individual level is when unaddressed hearing loss, it impacts listening and communication. It's clear, language and speech development, cognition. Even a unilateral hearing loss affects the development of cognitive skills. The hearing loss is the largest potentially modifiable risk factor for age-related dementia. There were studies, I do not want to read loudly these studies now, which show that unaddressed hearing loss may responsible for over 8% of cases of dementia among older adults. Education is influenced by hearing loss and employment. Students with hearing loss often demonstrate a lack of career planning and decision making. Overall, adults with hearing loss have increased odds of unemployment or underemployment. I refer to these studies from Finland and Norway shown here. Social loneliness is a big point for people with hearing loss. Mental health, social withdrawal, and altered social interactions are frequently observed in people with hearing loss. Relationships. Over 90% of deaf children are born to hearing parents, and those parents often have difficulties if the hearing loss of their child is not addressed sufficiently to develop meaningful communication with their child with hearing loss. In adults, the hearing loss can have a negative impact on personal relationships, resulting in communication difficulties, misunderstandings, and conflict. This effect is evident both for the person with hearing loss as well as their communication partner. Identity, self-felt identity, and a self-felt stigma is often underestimated by people who are not have this problem. Okay, my last slides. The hearing loss has a considerable economic impact on a society as a whole. WHO data reveal that the overall global cost of unaddressed hearing loss is greater than 980 billion annually and exceeds the costs for addressing hearing loss. These 980 billion annually include costs related to the healthcare sector, about 300 billion of more healthcare which is necessary for people with unaddressed hearing loss. Educational sector, about 27 billion for providing support to children with unaddressed hearing loss. The loss of productivity, costs related to unemployment and premature retirement is conservatively estimated 182 billion annually, a big part. Societal cost, the result of social isolation, communication difficulties, and stigma, at a further 456 billion each year. It has also to be mentioned that more than 50% of all costs are attributed to low and middle income countries. Here is a graphic. So this was my part. I guess if you have questions in the end, of course, it's only pure text reading, but it's nice to have written or contributed to this text. But there are so many interesting aspects in this text that we wanted to show you parts of this report. And now my colleague and friend Philipp will do next part.
If you could stop the sharing, and then I'll share mine.
Okay.
Question concerning
you may share already because you are a co-host.
Can I overrule you here?
Yeah.
Katrin,
they try it.
There is a question in the chat.
Yeah, I see the question. So,
Here, hello.
Okay. Oh, I lost the chat, but now.
Can everybody see solution across?
Yeah, we can see it. We can see there's still a question in the chat from Bettina. Are there long-term data about hearing loss in SARS-CoV-2? Where should we get long-term data now in newborns? Could it cause late onset hearing loss? Honestly, I do not know much about it because I guess it's not yet in the report. But I will check it and write you the answer into the chat. So now the floor is to Philipp.
Thank you very much. Yes, I would like to talk about some other parts of this very interesting global report on hearing. It's basically split up into 4 sections, and I'm going to talk about the last 2 sections now. So the first step the WHO is asking is to acknowledge and to recognize these numbers Katrin just presented concerning the prevalences and the causes of hearing loss and ear problems. And the next step would then be to attack these problems. So this part is about solutions across a life course, which is the main line of this, basically the red thread within the story of this global report, that we always want to look at a person not in the very moment, but in the course of a whole life, and which is the only way how we can address preventive measurements. Many of the causes that Katrin already mentioned can be avoided. In children, it is nearly 60% of hearing loss that is due to avoidable causes, especially if we look into the close to the equator countries. Things like otitis media, which we see a picture here on the right, are still the main risk factors for hearing loss that is then permanent if the otitis media in the acute state in the beginning is not addressed. So therefore the WHO is asking for more awareness globally and nationally for these causes that can be avoided. Katrin already talked a lot about these preventive measurements like immunization, maternal and child care practices, and all these other things. So I don't have to tackle that so much anymore. So solutions across a lifetime that can be addressed is that we keep in mind the picture of a life. So we want to maintain the hearing trajectory is one of the main goals that the WHO is asking for as a person ages, and influence hearing loss at all ages. Therefore, we need to implement, or it is asked to implement on a national level and therefore globally, these detection programs, identification programs, basically on 4 levels. These 4 levels are, first of all, newborn and infant hearing screening, which we already have, for example, in Germany and many other countries. I'll come to that a little later. But also in school-age children, where they are in very noisy surroundings where there are also certain risks, and also different kids are differently exposed and differently have different preconditions and therefore a different risk to get a hearing loss. And the third group would be people at a higher risk of hearing loss due to ototoxicity, which we just heard about in the very nice talk of Antoinette Hansen-Dinissen, and also the older adults. Of course, the older adults is very obvious, but there is no universal screening for older adults that really everybody gets addressed, like we do see it in melanoma screening or colon carcinoma screening. But the impact of hearing loss is actually at least as high. If we want to look at occupational settings, there the WHO, I take this as an example, gives very smart 5 steps that have to be addressed for a good program. So I'm sorry, this picture is slightly blurred. So they say we need to reduce noise levels. So we need to have an awareness for the noise levels in an occupational setting. We need to monitor this by smart devices, which is, for example, apps that you can have on your phone or actual measurement systems. The use of protection, the hearing protection, education about the problem, and hearing surveillance. So basically monitoring the people themselves that are in an endangering situation, in an endangering environment for occupational hearing loss. If we look at the next slide, there is one example that is developed by the International Telecommunication Union, which is a smart device that basically pictures how much loud music or noise you hear from your phone or you hear in general. And Katrin already mentioned that they say 40 hours per week of 80 decibels is what should be the maximum of basically hearing impact to save your hearing for a long life. For example, this noise dose can also be reached by just listening to 100 decibels for only 4 minutes. So just to have this in mind, and if we go to a party in Berlin, for example, the noise levels can exceed 120 decibels in some clubs. And there is basically no awareness for these young people who go clubbing there, who come out with sudden hearing loss and other problems and never heard about this problem or don't know that they actually damage themselves for a lifetime. For this reason, it is super important to create policies of awareness. If we look at other fields in life, for example, cigarettes, where it is a policy in Germany and other countries as well, that cigarettes cannot be advertised for in news, in TV or in radio. Or we have these pictures on cigarette packaging that is warning that the risks that are within cigarette smoke are applying to everybody's life. Just to create this awareness. Or another example, that people have to wear a seat belt. We need to create an awareness that is then changed into politics and health politics in special, to address these problems and to create more awareness, and also these things that have been applied for a cigarette, for example, reduced cigarette smoking in the society very much. So we see with this example that measurements like these policies actually have an impact on the people and work. So it is important also to detect the hearing loss very early. Very early doesn't mean at young age, but means at all ages, when it appears. For this, we need these 4 levels of screenings that I just mentioned before. Here, they made a comparison. If it is useful to address a universal hearing screening program, or if we should just, for economic reason maybe, address the people who are at risk. So an at-risk program in different age groups and risk groups. And another one was an opportunistic program where basically people could go and could decide if they want or not. They compared these and saw that there are clear benefits, not only for the people, but also economic benefits in a universal screening program. If we look at this, the high quality early hearing detection and intervention programs should include the following things. So a universal newborn hearing screening, surveillance of those people at risk, or if we want to make it universal, then the comprehensive diagnostics to quantify the hearing loss so that we can actually tackle those hearing losses with a correct treatment and rehabilitation. The parental participation and family engagement, so it should be addressed that there's hearing loss is not an individual problem, but also a problem for the social surrounding, and therefore here the next part, social and psychological informational support is very important. And further, we have to look beyond the horizon and look at different problems and other etiological investigations if indicated in the situation. So I just talked about the economic aspects of such a universal screening, and already Katrin also talked about the fact that hearing loss in general has a huge impact and a growing impact on the world's economy. For this reason, it is maybe nice to illustrate these two examples. It is cost efficient to implement these newborn hearing screenings in high-income countries, also as in middle-income countries, and that was what the study was about. For example, if we look at China, the long-term costs of a screening program come back basically by better results in the hearing care at a factor of 7.152. So basically what you invest in such a hearing screening program, you get as a state in the running economy out 7.52 times. Another example was an analysis that was done in India, where they revealed that there is a lifetime saving, including the social costs, of over 500,000 international dollars per case, identified over a lifetime. If you, at an early age, for example, detect a hearing loss and then address it properly and make this person hear and have a proper interaction, a proper social life with no restrictions or as little as possible, and therefore all the perspectives and options in the professional life. I also had to look up what international dollars are. The exchange rate today is 0.83 euros. So we're talking about 400,000 euros here, basically, to translate it for those who don't know what that are. Exactly. So the identification, we come to the next age group now, in school children is also very important. This is not very easy because they are not very interested, and you have to basically pick them where they are. For this, the WHO suggests smart applications, automated hearing screening, boothless audiometry, telemedicine options, or mobile-based, which is a very good way to address young people, mobile-based software applications that are not bad at all, and therefore should be addressed to people at those ages, to the kids at those ages, in order to screen them. So the next group would then be the older people. Also in the older people, a screening would be cost-effective, studies showed within this report. There are very good recommendations given by the WHO for guidelines for an integrated care for older people. One main thing is that awareness has to be raised. I mean, we cannot say this often enough today, but there is just not awareness. When we see in the clinic people who have hearing loss and are of older age, and maybe they come even for another reason, if we address that they have hearing loss, it doesn't really seem to be in their horizon in many cases that this is actually a problem, because it's so subtle sometimes and the problem just grows slowly and is therefore sometimes ignored. So community awareness is a very important thing. Then also healthcare professionals should have an raised awareness. They should screen periodically. This is especially, I mean, ear and ear, nose and throat doctors or audiologists, audiologists. They do this, of course, on an everyday basis, but especially people who treat older people, general practitioners, should also focus on this age problem. Otoscopic examinations and other things are very cheap options to actually screen for problems, or the whispered voice test. Hearing devices should be made available, and to improve the daily functioning and to actually make the person take part in the social life at 100% if possible. Medications should also be reviewed. Also here we are again at the ototoxicity, and the chronic otitis media or sudden hearing loss should also always be addressed and not ignored, as Katrin just before said in the example from the Philippines, where the kids sit with the running ears, the otorrhea, and this doesn't get addressed. So they made a big study to have a look, so how efficient this actually would be. And it was shown that by a cohort of 100,000 people, you could gain 30,000 quality adjusted years of life as a gain if you apply a consequence screening program nationally wide. So this should be a great motivation to do so for politicians in all places of the world. And this includes, because we're talking about older people, people who even are just 55 years old. This is when the screening should start, so comparable to colon carcinoma. We saw just a minute ago in the graph of Katrin that the prevalence of hearing loss with 60 makes the big jump basically, and then goes up very steeply. But also at 55, you already see the first jump up, while the time before it is pretty much stable. Challenges, how to face ear and hearing care. So this all looks quite practicable, but in the end, there are some challenges that we have to face here. So one problem is the demographic and population trends. So we are becoming more and more people, and the people are becoming older and older. For these reasons, we see a growth also in these age-related diseases, such as hearing loss. Education of people is a very important thing. And what Katrin also said before, a stigma that we don't really know about if we are not confronted with hearing loss is very widely spread amongst people who have to face this problem, that they are ashamed of it, they try to cover it, and therefore the destigmatization basically has to happen in order to face this problem publicly and as a whole society basically. And then, of course, structural health system related issues are a very big key factor that has to be addressed. If we look at this, this is basically what I said in the first point, just above, the change of demographics in the world. Here we see a projection basically into the future from 2019, when this report was still in the making, to 2050. And we see here that the disabling hearing loss, so the higher or moderate, at least moderate or higher levels of hearing loss increase quite a bit over time in the next years, just naturally by this trend of the society. And the disabling, the overall hearing loss, so the small hearing loss, let's say the lower one, is also growing up quite high, and therefore should be addressed, especially now with the new international classification of functioning, where not just the hearing loss and the number of words that a person understands is taken into account, but much more what the person experiences and how much this person is maybe secretly suffering from this hearing loss, and therefore it should be addressed very harshly. These are the trends here. If you want to look at different regions, there has been a big lot of work done by the WHO and all the people who are working on this report to collect the data from all regions of the world to see how the numbers will change over these years. And we see that in the Asian region or West Pacific region, and also in the African region, it is the steepest curve, basically, if we look at this curve here. Here with us, for example, in Europe, it is much lower because we already grow very old. and because we have already a very stable healthcare system in most countries in place, where in other countries, in other parts of the world, people are troubled by tuberculosis and other things that we don't see so much here anymore, and therefore the medicine that arrives there now leads to an exponential growth in older people within the society of those regions. If we look at the world, it is a split world. It is a world that is not fairly divided, and we have to, when we want to address these things globally, look at the differences and the inequality in life. Therefore, I wanted to give this little overview that if we pay attention worldwide, only 17% of those who would benefit from a hearing aid actually use one. So this is a very, very low number. And that means that 83% of the people who would need a hearing aid in the whole world don't have one. And this is quite alarming. If we look at other things like screening measurements, for example, in the world, for example, the newborn hearing screening, Katrin has done a big study together with others, for example, Carl White and Shelley Shada, and a big international group from all countries, where hearing screening, newborn hearing screening was evaluated in almost all countries of the world with numbers. And here we see a very direct connection, a correlation between the gross domestic product, so the wealth basically of a country, to the hearing screening. We see that a third of the countries have basically no hearing screening, or less than 1%. One third has a medium one, up from 1% to 84%, and another third, which is the industrial countries of the world population, with their big gross domestic product, have a good hearing screening, newborn hearing screening implemented with 85% or above of the newborns getting screened. This is very important, and this is another thing that international efforts should focus on in order to place the trajectory again of a life in order to make a better hearing care. So here, talking about the divided and unequal world, we see it's a bit difficult maybe to see the color difference, because it's only like from a slight pink to red. But we see basically a trend on the equator zone. First of all, that the gray areas are countries where it was very difficult to get data, or basically it was not possible to get data, and due to, in most cases, structural reasons that are also saying something. And on the other hand, if there were numbers available, they were very low, these pink numbers here, these areas here or here. This is, for example, a picture that illustrates how many ENT doctors are there. And we're talking about ENT doctors per million of population. So in these countries here, Madagascar, for example, there is 0 or 1 ENT doctor per million people. So this is also alarming, and showing and basically explaining why this report is important to create more awareness for this problem. Another picture here we see for audiologists, experts in audiology. There it's even more difficult. Or here in language, speech and language therapists. That is also not spreading much. Of course, here in our western parts, and also in Australia or parts in South America, South Africa as well, it is very good, but in other parts of the world, it is a completely different story. So what is needed? The WHO is trying to summarize this. They say we have to look at this projected growth of population and of aging. And people at all ages need help and need hearing care. It's not just old people or just young people. It needs to be addressed universal over all these 4 age groups that I just mentioned. And urgent action has to be taken before this problem of a growing world population and an older getting world population basically comes falls out of our hands, and we are facing a problem that is even bigger, and economic consequences that are even bigger and disrupt the world in this sense even more. So it is important to pay special attention to vulnerable populations as well, and to generate access to ear and hearing care. Further, accurate information to reduce the stigmatizing mindsets in order to make the people at all psychologically able to address their own issues and needs is very important. I keep saying things are very important. What we also saw while reading this report was that even among healthcare providers, the knowledge is not there enough, and even there, the education and the information has to happen in order to support people and the population better. What is needed, part two, is basically action. The WHO, in their global report, the World Hearing Forum, they made a very clear statement: the time to action is now, and we need to start working on this. So I pictured here the three big things again: the demographic population trends, the lack of education, basically, and the structural health system related issues, and how we can face them. And what we need is government leadership for ear and hearing care integration, often lacking. We need to overcome challenges. So we shouldn't be scared of this challenge, but actually accept it, which we have done in other problems in the world already by addressing big health strategies, so national-wide health strategies. Diseases were tackled in a way internationally that they got eradicated more or less from the world. So if this same awareness and this same effort would be made in this field of hearing loss and ear and hearing care, there would be quite good chances to reduce this burden. Then we need to create an access, which is probably one of the most difficult problems, that there is an equal accessibility of ear and hearing care and hearing devices spread over the world, and we have this split apart world a little close together. So the WHO, in the last part of their report, tried to design a way forward. They tried to say, like, okay, this is now asked a lot, and it seems all very broad-minded, but not very clear as what to do actually. And therefore they made this very nice acronym, HEARING, it's easy to remember, where they basically show the steps that have to be taken, or the things that have to be considered while facing these improvements, and while trying to bring across these improvements in the ear and hearing care internationally, which is hearing screening and intervention, an ear disease prevention and management, access to technologies, as I said before a few times, rehabilitation services, which require a lot of knowledge, improved communication about the topic as well, and of course also communication of the people with hearing disorders, and noise reduction, concepts for especially occupational, but also for the leisure part of noise application to the ear, and a greater community engagement. So basically not only governments, but basically everybody is asked forward to make a step forward. Okay, recommendations are these. It's time for action. I'm going to summarize very briefly what is basically the last chapter of this World Report on Global Report on Hearing. We have to include an integrated and people-centered ear and hearing care in universal health coverage. So basically over all ages, and people-centered, individualized, and over the lifespan, the trajectory that we talked about a few times now. We have to strengthen health systems in order to cope with these challenges. We have to raise awareness and do campaigns like the campaign today, basically, to raise awareness and to address attitudes towards these things and to reduce stigmas. We have to determine targets, and there the WHO report helps very much, because they basically already deliver the targets, and monitor those targets and trends. If we actually succeed them, we have to re-evaluate the process step by step. It is important also to promote the subject of high quality public health research and ear and hearing care. So there needs to be research done, and especially research on public health. Because the knowledge is there, it's just a public health matter in most cases that the help that is available in the world doesn't reach all the people. So recommendations for, these were recommendations for ministries of health, so finger up. But these are now the goals and the recommendations for international organizations. We should align, or they should align, we all, with the goals of the WHO for ear and hearing care and support and monitoring these goals. It is important to improve knowledge and awareness, stimulate the generation and dissemination of this knowledge, and participate actively in a global action. So to give a little vision, they also give a recommendation to all the stakeholders in this field, the professional groups, civil societies, and the private sector, that there should be a support of the national governments, because of course governments can only do this if there is awareness not only in the politicians who are responsible, but also in a broad society. There should be contribute to the generation of knowledge, as I said before, but this is of course applicable to all the different groups. And there should be a collaboration of all those sectors and stakeholders with each other in order to create synergies and to make the most out of this vision that should be shared vision. And with this, I close, and I'm happy that I was allowed to do this part, and I'm happy if there's any questions that I or Katrin could answer.
So, Philipp, thank you so much. You were much quicker and more fluent in English than I was, but okay. We are at the end of our presentation. Are there questions? Are there discussions? Just ask.
There's one in the chat.
Yeah, the chat we have managed the chat. We didn't find, there is nothing about COVID in the report, except that people with hearing loss feel, have difficulties due to the face masks and the impossible lip reading. But I haven't seen anything about the affection of the ear. Questions, criticism, suggestions. Yeah, if this
it's a big homework. It's a big homework that is coming from this this talk, basically.
Although it was a long talk, I hope we stimulated you to download the report, which is now available on the WHO website, and read it. It's really worth to do it and take some action, as Philipp said. So we are happy to still get comments or emails if you want. And now we make a break, and then we have a last webinar for today about hearing loss in people with intellectual disability, and an upcoming, hopefully, universal screening, which we may get in Germany. So have a good time, and thank you so much for your kind interest. Bye-bye.